Assalamu alaikum. Welcome and on board, all of you. Anyone wants to ask any question before we start? Zishan, would you like to ask any question before we just start pediatric anesthesia?
अभी कुछ questions थे जिनमें वो जैसे आगे
communicate in English. Okay.
Right, sir.
Okay. So today we in the similar fashion we did pediatric. Sorry, this obstetric anesthesia. In the similar way, we will do try to do pediatric anesthesia. Okay. Whenever we face a pediatric patient, there are certain points which you should be knowing as a default, because that will be common to any pediatric patient which you are dealing with, practically as well as exam oriented. Okay, so first scenario from which I will start is a 4-year-old baby, known case of Down syndrome. Okay, and it is presented for adenotonsillectomy. 4-year-old child, known case of Down syndrome, presented for adenotonsillectomy. So what are the anesthesia concerns? How will you evaluate and how will you proceed? Zishan, would you like to start this question?
नहीं sir, down इतना अच्छा नहीं आता अभी.
Just start it. We will just start it. No problem. Just start it. Just start. Okay, Rabia, would you like to do?
Yes, Assalamu alaikum, sir.
Yes.
Sir, in this patient, my concern would be of pediatric age group, that is altered pharmacological, physiological, and anatomical changes, and concern of a Down syndrome patient, and concern about the anxiety of the parents, and preoperative evaluation and optimization of any comorbids or condition related to Down syndrome. In preoperative evaluation, I would, because these patients, my concerns would be basically the congenital anomalies, airway evaluation, and cardiorespiratory evaluation and optimization.
Okay. Rabia, just take a deep breath and restart, because you are very disorganized. Okay, just try to improve the answer again. 4-year-old child, known case of Down syndrome, presented for adenotonsillectomy. What are the anesthesia considerations? How will you evaluate the patient and how will you proceed? Again, please. You are trying to tell each and everything together.
Okay,
try to divide it in the patient-related, disease-related, for example, disease-related, patient-related, and surgery-related.
Okay, sir. Sir, my concern in this patient would be patient of a pediatric age group.
Anatomical, physiological, and pharmacological consideration, making the anesthesia management challenging in all the aspects, from airway to cardiovascular system to respiratory system to logistics. Okay, there will be changes which are, and then in next step, if the examiner would like to ask you, he can ask you, or in the next sentence you can say that fixed cardiac output altered, autonomic responses, cardiac difficult airway in the form of anterior larynx, short trachea, and in addition to the normal changes, there are additional presence of OSA and atlantoaxial subluxation, and you can make your answer like that. Okay. So just
Okay,
try to be in an order. You can combine either you can combine the consideration in a way that the examiner who is listening to you is listening the things in an order, not like one thing, then second thing, then third thing. Okay.
Okay, sir.
You can know it's not mandatory to divide all the things separately, but just try it. It should be in your filter that when you are telling, you tell in a way that you are in an order, so in sort of an order. Okay.
Sure. So, sir, concerns related to 4-year pediatric age group, which are altered physiological, pharmacological, and anatomical changes, and concerns related to Down syndrome patient, sir, these would be difficult airway because of macroglossia, macrognothia, and OSA, subglottic stenosis, and also large tonsils. Adenotonsillar hypertrophy, and there is these patients usually have cardiac anomalies like VSD, AST, and tetraphalate
endocardial cushion defects.
Yes, sir. And also there are recurrent chest infections, and they also have gastroesophageal reflux disease leading to aspiration pneumonias, and they have immunosuppressions and which can lead to recurrent infections, and also
chances of hypothyroidism, chances of epilepsy,
defect like hypothyroidism,
developmental problems
yes,
in the communication with the patient. Okay.
Yes, sir. Yes, sir. And also there is psychological dependence on the parents. Patient have low IQs as well as they are they also have epilepsy history, Alzheimer.
Not Alzheimer's.
Disease.
Not Alzheimer's. No. Alzheimer's disease is something else. Alzheimer's disease is something else. Okay.
Okay, sir.
And what else? Like, so now you will define it in categories that for ruling out cyanotic heart disease on the basis of history, examination, and investigation. Okay. So any history of choking, feeding history, and birth history, develop like the things related to that one. Where you can just tell that we will rule out cardiac anomalies, atlantoaxial subluxation with the chest, this X-ray neck, okay, and any history of epilepsy and concerns related to anti-epileptics if the patient is taking, and the drug levels and associated organ dysfunction because of anti-epileptics. You can use these words to tell, they will understand what you are telling. Okay.
So previous medical and history and surgical history as well for any kind of cardiac anomalies or other.
Yes. So what will be the thing which you will be planning in the preoperative part? Like you rule out any cardiac thing, and if it needs to be optimized, you will do that optimization. Okay.
Yes.
If there is some problem, there will be a multidisciplinary team to decide whether you have to treat the cardiac anomaly first or to do the tonsillectomy first. Okay. Yes, then you will be planning some other things like all the logistics required for the management of this patient, like preoperative anxiety, preoperative preparation of the room in a way which is suitable to a pediatric age group, like the temperature, size of bed, specific side of bed, so specific bed needed, specific maybe warming this mattress which is there. What is your gel which is attached with the temperature? There is a specific like that, and then you will be needing specialized equipment. Okay. Monitoring.
Difficult equipment, ultrasound, guidance, IV lines will be passed.
IV line, amla cream
can be used, and also
consent issues.
Consent and intellectual problems during induction.
Yes. So and because of OSA, this patient might need monitoring in HDU and as well as the chances of rebleed because of tonsillectomy. Okay. So you will plan all these things in pre-operative period. Okay, because in adenotonsillectomy and in this scenario, you will have even problem in ventilating the patient. Okay, because it can block it and you can have problem. So you should be ready even for if
pre-medication can also be done because they have dueling issues, and so we will give for anxiety we will pre-med patient with the midazolam.
Pre-medication also will be challenges because it can cause depression as well.
Yes.
Okay, so careful titrated pre-medication and secretions and all. Actually, we have covered and preparation of diluted concentrations of the medications with special care of the altered pharmacokinetic and dynamics of the pediatric age group. Okay, actually, these words which I am telling you, these are default for any pediatric patient. When you are explaining any pediatric patient, you can use the same word that you will be diluting and you will be using minimal possible syringe size, okay, to not only to decrease the pressure which you are giving when you are injecting the medicine and reduces the chances of air embolism, because air embolism may be very dangerous in such patients with having some because it can cause paradoxical embolism, paradoxical air embolism. So even few mLs of blood, few mLs of air can be dangerous.
Yes.
You have to be very careful about it, and careful labeling of the syringes with careful concentrations, and preferably to be prepared by the anesthetist who is giving it. Okay, yes, PDA as well, in addition to whatever we have discussed. Okay, so monitoring that specialized BP cuff, and if, for example, you are
requiring in this.
I'm sorry.
Sir, because of cardiac effect, if patient is not optimized or having some cardiac effects, an A-line would be needing for vigilant beat-to-beat monitoring.
Yes, this will be extra beat-to-beat monitoring, and plus as well as to do ABG if it is needed, and this one also pre-ductal, like you will be using right radial. That will be like, I don't think so this will be in scope of this question, because we have not touched anything about, because in this scenario they will be leading up to post tonsillectomy bleed even. Okay, so actually we are over time. I don't think so you will be needing to tell each and everything, but this should be in your mind that these are the things which you can compile. Okay, as you can use as much what you can start with the short words, and if they would like to expand your words, they will ask you to do. Okay. So okay, so we have covered almost everything: atlantoaxial subluxation, endocardial epilepsy, this one developmental problem, and some of the features are actually diagnostic, or they can ask you this question: what is Down syndrome? So it is trisomy. Okay,
trisomy 21,
low-lying ears and specific eyes, Mongolian eyes. Okay, so but I don't, if you miss them, they will not fail you on these things, but you should know. Okay.
Yes, sir.
Because Down syndrome is frequently asked, and actually maybe they are asking you Down syndrome in the way they are asking you about acyanotic and cyanotic heart disease. Okay. So they can ask you, they can twist you towards that side as well. They can take it towards tetralogy of Fallot. They can ask you about what is Eisenmenger phenomena. What is Eisenmenger phenomena?
Sir, in a patient having any cardiac anomalies in which there is a left to right shunt, ultimately with a chronic condition of this patient, ultimately the shunt is reversed due to increase in the pulmonary vascular resistance. So when the shunt become from left to right to left, then it is known as Eisenmenger syndrome.
Eisenmenger, like you are chronically slapping the poor and sophisticated lungs, and one day they are angry and they are slapping you back. So that is the virtual example of what it happens. That in in fetal circulation, there is no circulation to the lungs, and when it is switching, so if there is any if there is any intracardiac shunt, okay, that is usually from left to right, okay. But chronically, if it is not cured, then this is resulting in pulmonary hypertension, okay. And then pulmonary hypertension, when it occurs, actually whenever there is this balance between pulmonary vascular resistance and systemic vascular resistance, if systemic vascular resistance is decreased, right to left shunt is increased, okay. So that's why in the perioperative management, if there is cyanotic, like there is a decreased saturation, or in awake patient, if there is cyanotic spell, they are doing squatting to increase the SVR, okay. And in perioperative care, if you are facing during intraoperative period, if you are facing any hypoxia, you will be giving fluid and you will be giving phenylephrine to increase the systemic vascular resistance to reverse the shunt, okay. So this is
increase PVR. Also, avoiding the factors will increase PVR like hypoxia, hypercarbia,
acidosis, my best friends, okay.
Yes,
you will be doing that. Okay, so now coming to the concerns related to we have covered almost everything about Down syndrome. Some of the things are left for pediatric age group, like you will be these babies are having fixed cardiac output. These babies are having high oxygen consumption, low FRC. They can desaturate early. So this is one thing. And they have altered pharmacokinetic. They have high volume of distribution, high blood volume, okay? And they have low metabolism and low excretion. So there will be increased requirement of induction doses and decreased maintenance doses will be required. What will be the effect of MAC in 4-year-old? MAC will be
increased in pediatric age group.
Okay, so this is one thing. And what will be the effect of MAC in right to left shunt or left to right shunt? Both IV and inhalational.
Sir, for IV, it is delayed, and for inhalational is...
What? Right to left or left to right?
What, sir?
What, right to left or left to right? One by one. Talk about IV in right to left and left to right.
Right to left shunt. Are you asking about shunt?
Yes.
Sir, IV induction is prolonged in right to left shunt.
Prolonged or fast?
So fast. It will be fast.
IV induction will be fast.
Yes,
okay.
Sir.
Slower in left to right.
Yes, sir.
Okay. And inhalational agent, inhalational induction?
Sir, it would be fast.
For everyone, which will have more effect? Desflurane or halothane?
Sir, halothane.
Why?
Sir, I'm sorry, I forgot it.
Think about it, because desflurane is least soluble, okay? So desflurane is already, desflurane is so lazy, it doesn't want to go in the blood anyways, okay?
Yes.
So it will have less effect on desflurane and it will have more effect on halothane, okay? So
yes, sir.
In right to left shunt for halothane, what will happen?
Slow induction.
Slow induction. Okay.
Yes.
And left to right shunt?
Fast induction.
Okay. So this is how you just can be asked. These will be extra questions, and that is what actually in especially in the normal scenarios in table vivas, I don't think so they will ask you more than that for cyanotic and acyanotic heart disease. Okay. They can ask you what are different components of TOF, or they can ask you this thing which I have told you. Is MAC syndrome effect of IV or inhalational induction in right to left or left to right shunt, which is more affected, how you will manage, how will you avoid increase in pulmonary hypertension, how can you evaluate these patients preoperatively. So this is extra knowledge that if you want to be, you can get some information through echo as well, but if you want to be sure, you need to have right heart catheterization. Okay. So the exact answer to the level of pulmonary hypertension will be on the basis of doing right heart catheterization, and they do it, and they also use a pulmonary vasodilator to check the responsiveness, because according to that they will decide what is the intensity and how much is the reversible parameter which is reversed by nitric oxide. Okay, so this is high question, but this is just it should be in your mind that how they can, if they want to, they are just playing with you and you are answering, and then so this is the maximum that exactly if you want to see the level of pulmonary hypertension, it will be done through right heart cath. And then there they use number one, they try to use the to try to have the real time scenario. So they ask to reduce the FiO2 as much as possible, like they are just trying to see the condition in room air, like they just make it 21% oxygen, and then they use nitric oxide. Okay, so this is maximum which they can ask you related to Down syndrome. Okay, so these are the things. Now coming back to tonsillectomy. So what things you know you have to mention about adenotonsillectomy?
Yes, sir.
What will be done?
Sir, in adenotonsillectomy, our concern would be the active infection.
Okay, very good. One thing.
Yes, sir.
You don't have to do it. You try to have the window in which, because you cannot delay it. Okay, you cannot delay it, but you will just try to have a window in which there is no acute infection, because it will cause excessive bleeding. This is one point. Number two.
Also, rule out any coagulopathy.
Number two, okay, fine. Number three.
And sir, any
OSA, you have told already. OSA.
Yes,
OSA is related to it. Okay. Then you have to this one. You have to see the severity, like how much is there any. Like there will be history of snoring. There will be history of. So you have to see the severity. This is, and other concerns will be related to bleeding, shared airway, throat pack. Bleeding, shared airway, related to kinking of the tube because of Ball-Davis mouth gag, any injury to the area, okay, and kinking of the tube, kinking of the tube. So you should be using Ayer's as reinforced tube, so that it is a little bit kink resistant, okay. So the tube is a little bit kink resistant. You should you should be knowing the concerns. What are the concerns related to throat pack?
Sir, first of all, we put the throat pack to save the aspiration of okay, blood.
Fine. Go ahead.
Collection of blood.
What else?
So the concern would be to remove it promptly before extubation from the airway, and
it should be notified when you are putting it. You should say throat pack in, and the circulator nurse should be noting down the time. Okay. Usually the throat pack should be long enough, and it should be in one piece rather than broken pieces. Okay. And ideally it should be attached outside so that you know it. Okay. And the material of the throat pack should be the way it should be soaked properly. It should be like lubricated properly. And
absorption capacity should be there.
Absorption capacity, or it should be, the material should not be like rough to because it's a big source of throat pack. As much as you you should not be putting it too much. Okay, ideally you should be putting it in a way, appropriate way, so that it is blocking the airway and it is but it is not causing too much. Okay, so because it will create too much pain. Okay, and if you retain you forgot to remove it back, it will be a big source of pain. Sorry, airway obstruction. Okay.
Okay, sir.
So these are the things which they can ask you about. This one about tonsillectomy. Okay. So then next question they will be asking you what they will just go into the details at what will be the post-operative. When will you extubate the patient? Fully awake. Okay. And fully awake and make it barking dog position or sniffing dog position, what you say, and make it on the left lateral. So, and then, one more thing I forgot is the technique which they are using. If they are using too much cautery, so there are more chances of bleeding. This is called as hot technique. And the cold technique in which they are using the crushing stuff. So actually there is no absolute technique. They are mixing it. They are using some cautery. They are using some stitches. They are using some crushing. So, but you should be knowing that if they are using too much cautery, this is in that patient, you will need to give more analgesia because there are more chances of bleeding in that scenario.
Yes.
And they can ask you about in the bleeding, they can ask you about the arterial supply of the tonsils. So I think it is from external carotid. You should be knowing it, because if you are not able to control it, you should be knowing about the anatomy and what is the arterial or venous, because that's important. Okay.
Yes,
so they will ask you that patient bleed. So how will you evaluate that patient?
Sir, first of all, I will deal the patient with the airway bleeding and circulation, and I will maintain airway and pass IV line, and call for help and review and would resuscitate the patient and take some brief history and of the patient, and would review the anesthetic management done during operation. And also for
you are not telling one very important thing. It's evaluation of the level of dehydration.
Level of dehydration.
Okay, and dehydration or level of bleeding, hypovolemia. Not dehydration, actually, hypovolemia. Okay. So how will you evaluate in a 4-year child?
Sir, through vitals. And also through some clinical examination like mucosa, skin turgor, capillary refill, skin, and also urine output. And in vitals, I would like to see tachycardia, blood pressure, and respiratory rate, and also GCS of the patient. And I would send CBC to check for the hemoglobin and the blood loss to assess how much blood is lost.
Because actual blood loss is difficult to be assessed, because whatever blood is coming it's not going to the stomach. Okay, so a patient is at risk of patient will be considered as full stomach. And there is risk of aspiration. Okay, there is risk of aspiration, difficult to assess, and because the babies, they have limited blood volume, so you have to be very meticulous. Okay, and the usual signs of hypovolemia may be obscured, because patient can have pain and their patient will be tachycardic. Hypertension is not a very clear sign. Okay. And the other signs, yes, if it is a younger age group, the signs of dehydration are additional to what you have told, fontanella. Okay, but other mucous membranes and skin turgor and urine output and all this stuff. A younger child, they have to see the nappies, because you cannot calculate the even urine output very nicely. Okay, so these what you have to tell, and then you will label it as mild dehydration, mild hypovolemia, or moderate or severe, or in form of dehydration, or you can say about the hemorrhage. Okay. So it will be a little bit tricky because you cannot estimate the exactly as you estimate in adults. It will be difficult. Okay. So whatever you are doing, you will be doing the ABGs. You can just send the sample. And as you told, airway, breathing, circulation, you will try to maintain the airway. And you will have challenges in the intubation because it will be second intubation. It will be, patient will be at risk of aspiration, and there will be some airway edema. So you will be needing, as you said, whatever you are telling, you have to tell what you want. Review the size of the tube because you have to manage the airway. And when you were saying history, you have to see patient vomited. So you can ask about the character of vomiting, what has happened. Because if it is coffee colored, so it is like, it will be like that. Okay.
Yes, sir. I will discuss the surgeon about the plan. I would take consent again from the parents and reassure them, and then would resuscitate a bit patient, and then I would and also if there is blood needed, then I would inform the lab.
You will send for blood. You will send for blood. Okay. And
yes,
regarding the blood, they can ask you that how much, for example, if the hemoglobin has the result which you have got is, for example, 8.
Okay,
how much blood you will give? What will be your target? And how much blood will you give?
Sir, my target would be to in pediatric age group, it should be a bit higher than adults. It should be 12. So I would
12?
arrange.
No. Okay. How much blood you will give?
Sir,
usually we say in adult that we give 1 unit of blood and it will increase 1 gram. Okay. So
yes,
what will be in here?
And in Paeds, 3 to 5 ml per kg,
Not 3 to
PRBCs
5.
will
10,
increase 1 gram.
10 ml per kg.
10 ml per kg. 10 ml per kg. 10 ml per kg. 10 ml per kg will increase 1 gram per kg. Okay. So you said 12. I'm not sure about it. Okay. I'm not sure about it. You have to resuscitate and you have to you may be looking at the vitals. Okay. And I'm not sure that you will not give so much. 40 ml per kg will give to make it 12. I'm not sure. I'm not sure about it.
10 ml per kg is that I am saying that target of HP would be to higher than the adults.
Why?
So that's what I read in a book. I would
anyways reconfirm it because I'm not sure. So I will not. Okay. I would not like to tell you wrong. Okay. Anyone if anyone can Google it and get the perfect answer. Okay.
Okay, sir.
So this is one thing, and that they can ask you maximum about it. That there is risk of aspiration, risk of difficult intubation, and patient is very anxious. Okay, and you cannot delay it, and you have to proceed. Okay.
Sir, my concern intuitively would be to have the suction ready, an ENT surgeon scrub while doing induction. I would do rapid sequence induction, and then after intubation, I would pass NG and deflate the stomach and remove the blood which is swallowed by the patient. And also before I will remove the NG before extubation, and I will extubate patient awake in left lateral position.
Mm-hmm. Yes, yeah, these are the things. Okay, so now we will move on to the next scenario, infantile hypertrophic pyloric stenosis. So who will be take the lead? Zishan or Hamad, would you like to take it? Because most of the things are common. Okay, so who would be taking? Zishan? What is infantile hypertrophic pyloric stenosis?
Sir, may I?
Pyloric stenosis is basically it is a congenital abnormality in which the pylorus is the basically exiting orifice of the stomach, and it is hypertrophic. So there will be a kind of an obstruction, and the child cannot tolerate food. The child usually presents with projectile vomitings
this age
after
group will
feed
not be taking
in the
food.
initial days of life.
Sorry to interrupt you. This patient will not be taking food.
Sorry, I mean feeding. I said feeding.
Yes. Okay.
After milk, after feed.
Yes. Okay.
Yes. These patients are usually, they have an metabolically they are alkalotic. They have hyponatremic, hypokalemic, hypochloremic alkalosis.
Be a little
and
loud.
the suppression
be a little clear.
is usually
be
not.
A little, Zishan, be a little loud and be a little clear. Okay. Like you said that there is obstruction. Okay. So patient is presenting with projectile vomiting. So when there is vomiting, do you know there will be any difference in the vomiting in case of infantile hypertrophic pyloric stenosis and any other vomiting which we have in gastroenteritis? Is there any difference in these two character of these two vomitings?
It is non-bilious.
Yes. Okay. So in that area, when there is that vomiting occurs, usually the bicarb are also lost. Okay. But here it is happening in the other way. So that bicarb is actually absorbed. Here it is not lost. So here what is loss is volume, sodium, hydrogen, chloride, potassium.
Volume, potassium, sodium, and chloride.
Okay. So there will be hyponatremia, hypokalemia.
Absolutely.
Okay. Hypochloremia and and actually like metabolic alkalosis. Okay. So what should be the body response when there is decreased volume? Which hormone, what is the response of the body? Which axis is stimulated?
Renin-angiotensin.
Yes.
Sorry.
Yes. Okay. Renin-angiotensin system. So which hormone will be increasing, Zishan?
Aldosterone will be increased, and
so,
it will cause reabsorption of sodium, so
sodium?
that the
sodium will be absorbed and what will be lost?
Reabsorption of sodium
and a loss of
potassium will be lost,
and also
hydrogen ion will be lost. Of course, hydrogen ion along with potassium will be lost. So initially there will be alkalosis, but when the dehydration is very severe, then later on the body tends to
like when hypokalemia will be not sustainable to life, that will be actually hydrogen should be reabsorbed in this condition. Am I right? Because there is alkalosis, so the response of the body should be to contain hydrogen. Okay, should be contain hydrogen, but what will happen that it will be causing paradoxical aciduria. So now it will complete our our metabolic picture: hyponatremia, hypokalemia, hypochloremia, metabolic alkalosis with paradoxical aciduria. So this is what you need to tell when the examiner asks you what happens in infantile hypertrophic pyloric stenosis. There is just be very, very fast and very meticulous. There is congenital obstruction. Patient will have vomiting, and in vomiting this will happen, and this the body response will be like that, and resulting in hyponatremia, hypokalemia, as I told. Okay. So when you are giving, is it a medical emergency or a surgical emergency?
It's a medical emergency. We have to first resuscitate the child, and then
so
the case is not that urgent.
How will you approach this patient in the resuscitation? In a resuscitation of the
first of all, multidisciplinary approach. Multidisciplinary approach will be employed, will involve the pediatrician or neonatologist and the surgeons along with the anesthetist. For fluid resuscitation, we'll have to give.
Patient should be admitted in HQ.
First.
Rehydrate first. How for that you have to assess the hydration status. Okay, that which we have just discussed. It will be mild, moderate to severe dehydration according to the clinical sign symptoms. Okay, Fontanelle and mucous membrane and urine output. According to the severity, it will be like that. Okay, so this will be it should be your answer, that you will assess the severity of dehydration. You don't, in the exam, you don't need to tell in a way that you are, for example, if you are telling one thing, you are going in detail. Just give a clue, and if the examiner wants detail, he will ask you. Otherwise, he will let you speak. Okay.
Right.
So if so, you will say that I will assess the severity, and if it is mild, moderate, or severe on the basis of clinical history and examination, and then my aim will be to rehydrate the patient. Okay, and it will be percentage dehydration into 10 ml per kg. Okay.
Yes, sir. It's weight multiplied by dehydration percentage multiplied by 10.
10. So if it is 10, for example, if it is because this will be a smaller baby. So if it is, for example, 3 kg and 10% you calculated, so it will be 10 into 10, 100 into 300. 300. Okay. So you will be giving titrated doses, seeing the response, and so your aim will be to correct the electrolytes. Your aim will be to correct the urine output. Okay. And then you will be seeing the urinary chlorides. As soon as urinary chlorides are appearing in adequate amount, you will say that the patient is rehydrated. Okay. And patient is ready. Because if you throw the patient to the OR, patient will have central apnea. Patient will have dangerous consequence because of electrolyte imbalance. Okay. So this is one thing they would like to ask you, that when will you proceed? It's not a surgical emergency, it's a medical emergency. One thing, and then what fluid to be given for resuscitation? The commonly used Paeds solution, is it the perfect one?
No.
Is there any role of Paeds solution in any anesthesia now?
No, sir.
Not unless at all. It's if you have some enemy and you want to kill that enemy, you can give Paeds solution. Okay, so that's a terrible solution, and there is no role whatsoever of that Paeds solution in anesthesia now. So for resuscitation, you need to give isotonic fluids. For resuscitation, you can give normal saline, and then later on for maintenance, you can give ringer lactate, or because you have to maintain the hypoglycemia. Maintain the glycemic status as well. But necessarily, you don't need to give 10% to every patient. Okay, you can check the blood sugar and you can give accordingly. Not in all patients you need 10%. You can even give 5% dextrose saline, and preferably the maintenance can be dextrose saline, and resuscitation should be isotonic. Okay, ringer lactate or normal saline. In this scenario, because there is need of more sodium and more chloride, you can go for normal saline. Otherwise, ringer lactate is the better choice. So this is what should be told for any pediatric fluid management. The same answer is default. Assess the dehydration. Yes.
Specific to pyloric stenosis, as there is hypokalemia also. So do we have to put potassium in addition to normal saline, or we can use?
Yeah, you can give. You can give a combination. No? You can give a combination as well.
Right, but normal saline should be the solution of choice, not ringer.
Because initially, there is no fixed rule. Okay, you can have a combination. You can have a combination, right. But initial resuscitation, because you want the volume initially. Okay. So the best will be to start with, it will be normal saline, and later on you can have a combination. Okay, you can have a combination, and then when you want to correct potassium, you need to give magnesium as well.
Yes, sir.
Okay, because it will be needed. Okay, so this is how, and when you are giving anesthesia, this patient will be at risk of aspiration. So you have to do 4-quadrant suctioning. Okay, and you can do rapid sequence induction, or you can do inhalational induction according to the situation, but inhalational induction will not be a very safe option. Okay, because it can cause, there can be risk of aspiration. Okay, even with after 4-quadrant suctioning. 4-quadrant suctioning, and you are rotating the baby and you are doing suctioning in 4 quadrants. Okay, so this is what they can ask you, infantile hypertrophic. And don't forget, you have to start your answer with altered physiological, pharmacological, and anatomical consideration in pediatric patient, which we have already discussed. In addition, which we have not discussed, is the concern related to prematurity, because in this patient you can have all the concerns related to premature babies, which will have more chances of going in hypothermia, more blood volume, more underdeveloped systems. Okay, so prematurity should be in your mind, because this baby will have all the concerns related to prematurity.
Right.
Okay, so this is how you need to answer. Okay, so next topic will be congenital diaphragmatic hernia and tracheoesophageal fistula. Okay, because there is not much difference in the majority of the things related to these these two diseases. Okay, because both of them are, again, they are medical emergency, not surgical emergency. You need to optimize the patient. In case of congenital diaphragmatic hernia, what you need to do?
Sir, we need to correct the pulmonary hypertension.
Okay.
And also to correct if any right to left shunt and acid electrolyte imbalance.
Try to be a little more generous. Would you like to see other congenital anomalies?
Yes, sir.
Well, you will be seeing in the form of what is called as vector and vectral in both of them.
Yes, sir.
What is the mnemonic for?
Sir, it's vertebral defects, anal atresia, cardiac anomalies, tracheoesophageal fistula, radial dysplasia, and limb anomalies.
Yes. Okay. So you should be saying that my preoperative evaluation will be focusing towards these things. And specifically, if it is tracheoesophageal fistula, you need to see what type of tracheoesophageal fistula is there. You will be putting a you will be putting a tube in the blind pouch, do the suctioning. Okay. And your aim will be, in the both conditions, your aim will be airway breathing circulation. In case of congenital diaphragmatic hernia, because these patients indifferently will have immature lungs. So you need to mature the lungs. Patient might need ECMO and the aggressive treatment of pulmonary hypertension with nitric oxide. And you will be giving surfactant, and the baby will be admitted in NICU and managed. When the lungs conditions are better, airway pressures are better, then they will be heading towards the surgery. Okay.
So patient protective strategies and with pressure control. Sir, lung protection strategies are applied and pressure control ventilation is given to the patient until the
pressure control. And in the adduction, you would not like to ventilate the patient. Okay.
Yes, sir.
You will try to have the inhalational induction without positive pressure ventilation, because you can damage the lungs. Okay.
And without
don't we have to avoid positive pressure ventilation in these patients? We have to maintain them on spontaneous.
No, not in intraoperative period. Of course, in the during this is for induction. Okay.
Right.
When you have induced when you have put the endotracheal tube, then you have to ventilate, of course, but with the positive pressure control, with the limited pressures. And lung protective strategies with pervasive hypercapnia, whatever we can say. But it is the this one induction. Okay, it is the induction in which you have to be careful, because if you are inducing the patient in case of tracheoesophageal fistula and you are ventilating it, what will happen? Yes, Zishan, what will happen?
Sir, we can develop pneumothorax in the contralateral lung.
This is more in case of the congenital diaphragmatic hernia, because lungs are very soft and fragile. Here, what will happen?
We are talking about congenital diaphragmatic hernia.
No, we are actually, because we are short of time, we have to cover both of them together.
So gastric distension.
Yes. Okay. So gastric distension, what will happen? We are not concerned about aspiration at the moment. Why? Because this patient is already having a communication through which aspiration is already occurring. So you cannot do much about it. Okay. So your concern is that when you are ventilating, there will be air in the stomach, and actually patient's respiratory mechanics will be seriously disturbed. Okay. You will not be able to ventilate later on. Okay. So, so this is the important point, that you have to do the inhalational induction. You can do, of course, you can do suctioning to start with, and then try not to ventilate the patient, both in case of congenital diaphragmatic hernia and tracheoesophageal fistula. In congenital diaphragmatic hernia, once you intubate the patient, then you have to do the lung protective strategies. What is the strategy of choice for induction in tracheoesophageal fistula? How will you intubate this patient? Do you know, Zishan?
Sir, the choice will be awake fiber optic or an RSI.
Optic, yes, you can say, but okay, not RSI. Yeah, that's what I'm telling you. In RSI, you need to ventilate. That's what I'm telling you, Zishan. We cannot do rapid sequence induction in these patients. We have to do inhalational induction. How can you do rapid sequence induction in this patient? No. Okay. The answer is that what is your aim? Where do you want to place the tip of your endotracheal tube? Yes, Ishan.
Sir, beyond the fistula.
And above the carina. Okay.
Above the carina.
So how will you achieve this?
Sir, when we put in the tube, first we
because you know why I'm not interested much in awake fiber optic. You can say awake fiber optic, but the thing is that awake fiber optic is very challenging because of very limited size of scope. Okay, very small trachea. These are, just imagine, these are 3 kg babies. So like fiber optic is not very easy in this age group. Okay.
Yes,
this is one thing, and another thing is that you can confirm the position of the tube. Actually, they have the normal intubation, whatever any other. The problem is the placement of the tip of the tube. Okay. Yes, so how will you achieve it? You will do endobronchial.
Yes, then first endobronchial. Then we'll retract the tube and we'll see the point where we can hear the sounds in stomach as well as in the lung, and then we'll again advance.
Not in both. In the stomach. When you are listening in the stomach, it means you are at the place of the fistula. And yes, then you will slightly push it back.
Push it forward. Yes.
Yes. This is what they want to ask you. In AD, you know, there are apparently this a very haunted topic, but believe me, the way I am telling you, you will be able to answer even MCPS. It's least likely they will ask you this question, but you have to be prepared for it. Okay. Because this is actually a difficult question. So remember one thing, I'm telling you the buzzwords: premature baby, number 1. Number 2, associated congenital anomalies, evaluation on the basis of history, examination, and echo. You will say, definitely echo will be done. Electrolytes, you can say anything with the reasoning. You can say that CBC to see this, electrolyte to see this, chest x-ray to see infection, echo to see any other congenital anomaly, and thorough clinical examination to see other component of vectoral. Okay. So this will be the first answer to tell. In addition to that, you will have all the anatomical, physiological, and pharmacological considerations related to the premature. If the baby is premature, you have to calculate the post-gestational age. By the way, what is the concept of post-gestational age? What is post-gestational age? How to calculate it?
Sir, when the premature baby is born, premature is defined when it's below 35 weeks of gestation. Okay. When a premature baby is born, the concept is that we count the number of weeks after that to the level of 44 weeks.
No. The week at which the baby is born, for example, the baby was born at 30 weeks. Okay.
Yes, sir.
And then you will plus you will the
Add
age
the number of days,
since birth,
number of weeks,
number of weeks since birth. So, for example, if the baby was born at 30 weeks, and now a baby is alive since 4 weeks or 8 weeks, so the post-gestational age will be 38 weeks.
30.
And the concept is that some books say 60, some books say 50. You can say 50 to 60 weeks of gestation, the baby is at risk of post-operative apnea. So you will not do any elective surgery, you will not do any day surgery. And if there is any emergency surgery, you need to monitor the patient for post-operative apnea with the apnea alarm in the HDU for 24 to 72 hours. Like you can use any word about it, but this is the concept of post-gestational age, the age at which the baby is born, plus the age of the birth, age after the birth. You will add it and you should be achieving 50 to 60 weeks post-gestational to have any elective surgery. And before that, you should be worried. Okay. So these are the things which you should be knowing. And they will be asking you few troubleshooting that they can ask you what is the type, important type. So in the different, some people will be telling according to the number. The number you can see, even if you forget the number, it's not that much important. You should be telling what is the most common upper esophageal blind pouch, upper esophageal atresia with distal
communication,
distal tracheoesophageal fistula. This is the most common. Okay. So you should be knowing the other types, but people sometimes forget that what are the failing points. I guarantee you that examiner will not fail you if you don't tell the exact number. But if you tell the safety of the patient, what are the problems? As I told you, positive pressure ventilation, challenging, what are the challenging scenarios? What will be the, you will have to optimize the patient if you have to evaluate the patient, and then you have to proceed with the surgery. Okay. This patient will be dehydrated. So you will say that this patient, because it's not taking the normal feeding, so this patient can be dehydrated. So I will be evaluating the dehydration status. Okay. And I will be optimizing, and I will be evaluating the other. So you see now there is common thing. There are common thing.
Sir, one thing in TEF is that patients usually have aspiration pneumonias. So we have to correct the pneumonias before conduction of surgery. So yes, this is
optimization. Optimization, it can be anything related to it, like with the steroids, with the surfactant, with the lung protect strategies, even ECMO. Even ECMO may be needed. Okay. Yes. If you are not able to achieve the oxygenation, you have to do the ECMO. You have to achieve the minimum possible airway pressures before proceeding it. Because sometimes these patients are intubated and surgeries are not being proceeded till the time they are optimized. Usually the course of event is like that, because they diagnose, even these things can be diagnosed prenatally. Okay. So maybe if there is a risk, they are doing just after delivery, they are intubated. This is the same thing. Actually, this is called as exit. Sometimes they are doing surgeries in the fetus as well. But in this scenario, they maybe needed to be intubated. In addition to this, there are some reasons related to any congenital airway problems which are there, and in that scenario, they have to intubate while they have not cut the cord, because otherwise baby may not survive. Okay, so this is high level things, but at least you should be knowing that these are the important points which they can ask you. In addition to that, all the things which we have already discussed: theta temperature, IV line, monitoring, preductal concept. What is the concept of this preductal? If they want to monitor, because there are chances of PDA in these patients. So yes, preductal is the right radial artery, because the right brachiocephalic trunk arrives before the ductus arteriosus is attached. Okay. Yes. Okay. What else they can ask you is the...
Sir, just for
yes,
clarification, while intubating, the tracheal intubation of a tracheoesophageal fistula patient, there are 3 steps in intubation, right? First of all, we put the tube endobronchial. Then we retract the tube till the point when we hear sounds in the stomach. At that point, we again push it forward so that it is beyond the level of
and then
fistula.
you are listening bilateral.
Then bilateral, of course.
Okay.
Right.
So
Sir, this is when we are not using bronchoscope. Sir, can we, after induction, can we railroad the tube on the bronchoscope and go by watching the exact
there is
size?
no,
And
Rabia, listen, the safety I have told you, okay? There is no problem you can tell like this. This is absolutely perfect answer. But as I told you, that there is no absolute answer to this question, okay? You have to tell that you have to place the tube between the carina and
above the carina and below the fistula.
Yes, that's it. Whatever you want to do. You can say that awake fiber optic or fiber optic intubation can be done, but it is usually challenging. So this is the other way which we can use. Okay.
Okay.
So, another question they can ask you is in the congenital diaphragmatic hernia intraoperatively, suddenly there is a fall in hemodynamics and hypoxia. So it will be usually, you will check clinically, and most probably it is pneumothorax. So you have to put the chest tube. Surgeon will put the chest drain. Okay, and one more question they can ask you in this scenario or in this question: what is fetal? How fetal circulation occurs? Fetal circulation.
So fetal circulation starts with the umbilical vein.
Okay.
The blood goes, bypasses the portal vein. I forget a little from here. Okay. Well, when it enters the heart, it enters through the right atrium. And the blood goes to the left atrium from the foramen ovale.
There are two entry of blood.
Two entries, of course. From inferior vena cava, the blood will go to the foramen ovale through the foramen ovale to the left atrium, and while the blood coming from the superior vena cava.
This is highly oxygenated blood. Okay.
This is a highly oxygenated.
This is highly oxygenated blood, and it is preferably going from right atrium to
left atrium.
Okay, and then from left atrium to left ventricle.
From the left atrium to left ventricle. From the left ventricle, the blood is expelled towards the aorta, but from that it is shunted to the patent ductus arteriosus.
No. Here you are getting. No. Just a second. One step.
Sorry.
No. You are telling right. Relax. You are telling right. Only one step you are missing here. You bring the blood, oxygenated blood. You bring from the inferior vena cava from right atrium to left atrium, left ventricle, and then you put it in the aorta. You are missing one step.
Aorta into the systemic circulation. It goes into the systemic circulation.
No,
but the blood coming.
Listen. You are missing one step. Think about it. The brain needs more oxygenated blood. So right, this is the concept what I have told you before. The preductal. So this blood, which is highly oxygenated, is going preferably here, going towards the upper part of upper torso. Okay? Right brachiocephalic trunk. And then the ductus arteriosus with the deoxygenated blood is coming, which is coming from which pathway?
Right ventricle.
From the
the deoxygenated blood from the superior vena cava enters the right atrium. That blood goes into the right ventricle.
Very good.
And from the right ventricle going towards the pulmonary arteries, the blood is shunted through PDA into the aorta.
There is blocked by the protesters. Okay, so the road is blocked. So now the blood, that shunted blood is going from the ductus arteriosus to the aorta. And now it is mixed up and it is going to the lower half of the body. Okay. And then going finally from the area to umbilical
artery. And
there is one umbilical artery or two umbilical arteries?
Two umbilical arteries and one umbilical vein.
One umbilical vein. Okay. So that's the simplest concept of fetal circulation, which they can ask you. And the only thing that you have to do, bring the oxygenated blood together separately and deoxygenated blood separately. And you have to mixing up at this one PDA. And you have to remove the oxygenated blood before ductus arteriosus. Okay. So in this way, you are able to explain it. Okay, so now some abdominal wall defects. One is gastrochiasis and one is omphalocele. What is the difference between both two of them? Anyone wants to participate? He or she is welcome. Meher, you have exam. Would you like to say something? What is difference between gastrochiasis and omphalocele?
The omphalocele occur at the base of the umbilicus and have a hernia sac, and often associated with the other congenital anomalies such as trisomy and diaphragmatic hernia and cardiac and bladder malformation.
Okay.
In contrast, gastric defect is usually later to the umbilicus, does not have hernia sac, and is often isolated finding.
Okay, and another important thing in this scenario which you have told, that which is more dangerous, gastrochiasis or omphalocele? In which way? Which
omphalocele is more dangerous?
No, omphalocele is more dangerous or gastrochiasis? Which is open?
Gastrochiasis because of risk of infections.
Because there is no hernial sac, its gut is open. Okay, there is no hernial sac. So actually this can cause serious and there will be more dehydration here. Okay. So when they are asking you this question,
gastrochiasis the one with the abdominal defect without a peritoneal covering, and omphalocele is the one with peritoneal covering intact.
So that's what I'm telling you.
Yes,
then
sir.
if it is not covering is not there, the covering is not there, the gut is open, there is more heat loss. There is more fluid loss. There is patient is more dehydrated. So it need to be corrected earlier. Just confirm it because I have not studied it for a long time. If someone wants to correct it, I will be very happy.
Where I studied, I don't know, I've written it in my notes that omphalocele is
gastrochiasis is more serious and more dangerous.
Okay, Jamil, would you like to say something? Yes, J dot. Okay, if there is any doubt, please add to it. So main difference, and in addition, again, I'm saying you that because we started by doing the general considerations, and again, the general considerations will come. So believe me, if you know the general consideration, now tell me, is it difficult pediatric anesthesia or easy? Tell me honestly. If you are trying to read each topic separately, which I don't know what you are reading, but actually you are making your life like a hell. Okay, because the basic concept will again the same. All the logistics, all the physiological changes, all the anatomical changes, all the pharmacological changes, all the general care which you need, hypothermia, difficult IV lines, I'm saying again and again. And the important thing which you have to mention again is that what is the difference between gastrochiasis and omphalocele. This one word will explain everything. Okay. If I have told you wrong, please reconfirm it, because as far as I remember, I have told you. If someone can correct it, I will be happy. Okay. So one other topic which is very commonly asked is upper airway obstruction in pediatric age group. Okay. So Rabia, have you some other ideas, or we have our right?
Sir, it's good. Yeah. It's all about this topic.
No. Gastrochiasis versus omphalocele.
Sir, whatever is explained is like gastrochiasis is we do stage closure in it, and post-operative.
Stage closure is stage closure. The confusion which we had, that which is more dangerous. The isolated, I know gastrochiasis is isolated.
More dangerous because it is sackless.
Okay.
And there is problem of infection, dehydration, and electrolyte abnormality related to it. Hypothermia as well.
Yes. Okay. So almost we have covered 5-6 topics which are important. Okay, because pediatric anesthesia is a very big topic, but the basics are like this, which I have told you. They can ask you about sedation. They can ask you about how to alleviate the anxiety, how to take the difficult IV lines. If you have no other way, you will go for intraosseous line. Okay, because even central line is not easy to take in these patients. Okay, and cyanotic we have discussed. Upper airway obstruction. So what is the differential diagnosis of upper airway obstruction in pediatrics?
Sir, may I?
Yes, please.
Sir, there may be epiglottitis, croup, bacterial tracheitis, and retropharyngeal abscess, yeah, tonsillitis in this map.
Okay, so you have told
the most common are inhaled foreign body.
Yes, it will be depending on the age. Okay, it will be depending on the age. Yes, foreign body is very common for obstruction, and rest of the things. So it will be presented as what will be the signs and symptoms. Yes, Meher, please.
There will be stridor and spatty. In this way,
you know, please, if you can remove the mic and you just remove the headphones and speak directly because there is too much noise.
Sir,
what are the important things you should be targeting first? I cannot hear you. I'm sorry, I cannot hear you.
Speaker, it is out of order. That's a headphone.
Yes, please try.
जो है वो dyspnea, stridor and tachycardia in this patient. और इनमें.
So how will you evaluate? What will be your approach?
So my approach will be ABC and जो है applying.
Listen. You when trying to use airway breathing circulation, I will make sure patient's airway is patent. I will make sure I will prop up the PAPI, okay, and I will at the same time evaluation and resuscitation and history will be going side by side. Okay, so you speak like this again, please.
So I will approach the patient via ABC and I will make sure the airway is patent. Assessment and management will go side by side. I will administer high flow oxygen as tolerated and call for help to the senior anesthetist and also ENT. And if I am suspect, as this is a case of foreign body, I will follow.
How will you make the differential diagnosis? In what way you will be like you are seeing this thing, you are going towards that thing. Okay, so what will be those things? What can be the associated symptom in addition to stridor? You have only told the stridor. What are the warning signs in this scenario?
There may be a drop in saturation and I will evaluate on the basis of history, doing examination and certain investigations.
No, Meher, listen. You are telling the things which have no meaning. What is history? What is examination? You have to tell that if this sign is there, what are the signs of respiratory distress? You have to tell those. Instead of using the word history examination again and again, examiner will be only irritated. You understand?
Yes, sir.
If there are signs of impending respiratory failure like decrease in conscious level, silent chest, nasal flaring, use of accessory muscles, sweating, then it means the patient is about to collapse. Yes, so instead of using the word, I will take history, this will not help you. You understand? So you be objective, yes, be objective, be precise. You have only 4 minutes to deal the scenario. If you are only using the word history examination, it will not help. Again, that's why I'm telling you very strictly. Okay? Yes, these are the signs of impending. So you will use the word. In the evaluation, my focus will be to see any signs of impending respiratory failure. Okay?
Yes, sir.
Because if they are not there, you have time. Then you can do anything in the world. This is one thing. Number two, what will be which will be important in your differential diagnosis, history of any obvious foreign body. This is number 2. Then what else you can do? X-ray. X-ray to see any foreign body. X-ray to see any sign of, like you X-ray neck or X-ray chest. Okay.
Yes.
So you will find, you can have some finding. If there is like, if there is some foreign body, there can be some segmental collapse or lung collapse there. You can see, and even any foreign body, if it is radio opaque. Okay. You can have it, the sign, yes. And then associated epiglottitis, epiglottitis you can see in the form of like what is thumb sign, or what is it is called as, anyways. So yes, so there will be some associated signs, like in addition to this respiratory, tachycardia, temperature. Yes. Okay, if there is high grade fever, then you are what will be the differential diagnosis? If this respiratory distress is with high grade fever, what will be your differential diagnosis?
Epiglottitis.
And what else? I'm sorry. What else?
So tracheobronchitis.
What is tracheobronchitis? If you are talking about laryngotracheobronchitis, it is CRU. Okay, so it can be, yes, it can be. But if you are talking about fever, high grade fever, there is one thing in addition to epiglottitis, that is bacterial tracheitis. Okay, that will have high grade fever. Or if there is prolonged history, the duration of history will also tell you. Okay, you can use the word that the history focus to the symptoms and the sequence of the events will tell you. Okay, if there is prolonged history, maybe the infected, if it is infected, then it can have high grade fever. But usually in CRU, relatively less acute symptoms, and usually CRU can have fever, but usually it is more prominent in epiglottitis or bacterial tracheitis, or as you told, these differential diagnosis of upper airway obstruction. You have mentioned in your starting words. What is that? Some mandibular abscess, retropharyngeal abscess, you told. Quinsy.
Yes, sir.
Okay. So in that, even there can be fever. So it's very important associated symptom. Okay. So in addition to signs of impending respiratory failure, CRU, signs of obstruction, patient irritable. In addition to that, if there is fever, you can see like this. Then there are some things related to inspiratory versus expiratory stridor. Am I right?
Yes, sir.
What are those? Yes.
Sir, doctor, sir.
Repeat the question.
Inspiratory versus expiratory stridor. Yes, Rabia.
Sir, if foreign body is in supraglottic, then the patient can have inspiratory stridor. But if it is subglottic, then patient can have V's or both inspiratory and expiratory stridor.
Okay. And okay. Okay. So this the character of stridor can tell you something. Okay, so how will you, that whatever cause is it, what are the different ways to manage your airway breathing? Early intubation may be needed in epiglottitis, and you should be prepared for all difficult airway management trolley. And in addition to that, you have to
be on board.
And ENT surgeon on board for tracheostomy, because like this patient can choke anytime. Yes. So this patient can have a complete respiratory obstruction. Other options which you will be using in case of epiglottitis will be antibiotics. Okay. Yes. What are the causative usually in this scenario?
Hemophilus influenza B bacteria.
Okay. And in the same way, you can say that patient might have the signs of of sepsis. So you, in that scenario, you have to deal the patient in lines of sepsis as well. Okay,
Yes.
according to the hemodynamics patient has. Okay.
Okay.
And when we were if it is viral crew, what are being used usually?
Sir, we use DEXA and racemic epinephrine nebulization.
Yes. Okay. So, and also another way to relieve the obstruction, what we do? Or increase the flow?
Heliox, we use Heliox.
Heliox.
But
okay.
It's related, can increase the concentration of oxygen. So we have to...
like if a high FiO2 is being required, then it will be difficult to use. Okay.
Yes.
Otherwise, in case of upper airway obstruction, you can use Heliox. So these are the things which you should be using. Early intubation, use of antibiotics. You have to see the associated symptoms. You have to keep ENT people on board. And how will you intubate? How will you induce this patient? For example, inhalational induction. Remember this thing. This is a safe answer. Whether it is foreign body, whether it is epiglottitis, inhalational induction. And what about IV line? Would you like the patient to cry, the baby to cry?
No, sir.
No, sir.
You will not try to have. Yes, you can say that in specific condition you can use EMLA and try, or you can give if there is no acute obstruction, then you can give some intramuscular ketamine, but it will not be a very, very safe practice. Okay, so it will inhalational induction and rigid bronchoscope should be ready. Things for tracheostomy should be ready. And for example, if you are try not to give positive pressure ventilation, because it can dislodge the this one further, foreign body. Okay, and another thing is that
sir, in this close cooperation between surgeon and anesthetist
is very important. Okay, and another thing is that when they have put the bronchoscope, you can attach the circuit through the side port, and you can ventilate. You can give anesthesia even or oxygenation. But again, you should try to keep the patient spontaneously breathing. So try not to give any medicines which are depressing the ventilation. Okay, and if it is causing obstruction, you can push the foreign body further. Okay, and once they have removed, then you can intubate. Okay, because and you have to give dexamethasone. You have to give you might need lidocaine infusion, or lidocaine will be helpful, and because this patient will have a lot of cough after surgery. So you have to.
So when the patient surgeon is doing manipulation with the bronchoscopy, then we shouldn't we spray lidocaine over there, or
whatever you do, you can do it. But you see the time when they are having the scope, okay, or when you have the airway in your control, it's not a problem. Okay, but once you extubate, like the surgery is finished, now the problem is more. Okay, because now the airway, whatever damage has been done while removing, like for example, if there is a thorn, okay, fish thorn or like anything like that, then it is it might causing some trauma, and there can be some post-operative edema. Okay, so in that case, post-operative care is very important. Okay. So lidocaine, even if you are not giving or giving, that's not a problem, because at that time there is bronchoscope and you have depressed the airway reflexes somehow. Somehow airway reflexes are already blunt. Okay, but once you extubate, once you finish the procedure, then it is more problematic. So at that time you can nebulize the patient with some bronchodilators, because airway reactivity will be there. You have to give dexamethasone to relieve the inflammation, and you have to give. You might need to have racemic epinephrine here as well. You can say anything, because you have to just take care. Actually, every answer you can give some antihistamines as well, which may have some role. But usually this steroids and lidocaine, and this is what you will be needing at that time.
Also, the warm humidified oxygen.
Yes, yes, warm humidified oxygen, high flow nasal cannula, or like you see, after they have removed the foreign body, then you need to have they usually use flexible bronchoscope to see any damage they have done. Okay. So actually, the spectrum of foreign body is very wide, and you cannot answer in one single word. Okay. So once we were you will be your approach will be you will say there is no generalized approach for upper airway obstruction, and you will be approaching the patient, and your focus will be toward history and in examination any associated signs. Okay, and especially signs of respiratory failure, respiratory distress, work of breathing, rate, pattern, signs of any obstruction, like nasal flaring, use of accessory muscles. Okay, and saturation is significant, but usually, even if the pattern is going down, okay, and because oxygenation and as well as ventilation, both of them are problematic. Yeah. Okay. So sometimes oxygenation is fine, but patient is retaining CO2. So ultimately, this patient will having CO2 narcosis. If he is not able to pull out CO2, ultimately there will be CO2 narcosis. Okay. So this is very important topic which they ask, and I have just tried to summarize as much pediatric anesthesia as possible in one session. If someone want to ask any question. One more thing which they ask specifically in the Saudi Arabia exam, okay, this consultant evaluation exam, they definitely ask a Spear-Robin syndrome or things like that. In that, remember one thing, awake fiber optic is the safest answer, okay, because you cannot even do inhalational induction because it can also cause obstruction, even if you are trying to give any sort of anesthesia. So it can cause. Similar is true for any anterior mediastinal mass. So you will have the same problem in that scenario. Okay. So any question?
Upper respiratory infection, regarding upper respiratory tract infection.
You have to cancel the case for 4 to 6 weeks.
Yes, sir. That was I wanted to tell.
Yes, 4 to 6 weeks, and actually, in some patients, like patient, yes, CP. Okay, those similar to that, the challenge will be in CP child because they have recurrent infection. So you cannot delay it forever. Okay.
Yes, sir. So one thing, upper respiratory tract infection.
Yes, please, Rabia, let him speak what he was saying.
Isn't it a little less time for upper respiratory tract and more time for lower respiratory tract? Like we delay the case for 4 to 6 weeks after lower respiratory, but lesser for upper respiratory.
Just tell me one thing. What are the danger signs? What is what factors will cancel the case? Any sneezing, any cough, or some specific things?
Fever, cough with sputum.
Cough with normal sputum or purulent sputum?
Purulent sputum.
Okay, so that there are some specific things in which you will be cancelling it.
Sir, I read in a book that for upper respiratory tract infection, it's 2 weeks, and for lower respiratory tract infection, it's 4 weeks, which is in Julian Ambarker. Sir, and also about a patient who is having runny nose throughout the month, and at that time we would discuss the case with, we would look for the urgency and also the comorbid condition and also the sign and symptoms. If patient have severe sign and symptoms, and so we would postpone it. But if patient has mild symptoms and there is urgency and it's all the time.
Actually, there is no fixed rule for it.
Yes,
Okay.
sir.
This will be again, you can, if you have any doubt, if you think examiner is not happy, you can use the word risk versus benefit and discussion
Yes.
with the team. Okay.
With the parents and team.
Yes. Parents, no, not parents. Parents, you just
Not
have to inform them. You parents, if they are thinking some non-technical thing, you cannot listen to them. Okay.
Sir, also one thing is that if we are proceeding with the case with mild symptoms, we would consider the pre-medication with anticholinergics and NABs with salbutamol or bronchodilators. And also we would try to use LMA instead of ETT. And
yes, you will do the risk stratification. Okay.
Yes.
Risk stratification in this form. Okay.
Yes.
You can use and this will be the you see in the books. I was just, while listening to you, I was just trying to have a look in articles. It is written 2 to 6 weeks. So it's both of them. Both things are coming. Okay. According to the severity, it is written risk of perioperative complications in the presence of acute infection, but remains increased for 2 to 6 weeks. Okay. So actually there is no fixed rule. Okay, you will cancel according to, but you have to let the patient come out of it. And if for example there are recurrent infections, you have to just try to find a window in between.
Yes.
Okay. Like if CP child who is bedridden is having chronic problem, what will you do? You have to do it. If some surgery is required, or any patient would, for example, a bedridden patient going for this gastrojejunostic tube and laparoscopic, what will you do? You cannot delay it. You have to do it. So it will be depending on the surgery, and it will be depending on the patient overall scenario. Okay.
Yes, sir.
So I think.
And in post-op area, it should be monitored for extra time as of any other pediatric age group without having upper respiratory tract or lower respiratory tract infection.
Yes. Okay. So what is the problem in Pierre-Robinson syndrome? Anyone remember?
So there is microkinetic and cleft palate.
Okay, so what will you be doing?
So due to microkinetia, there is difficult back mask ventilation, and due to cleft palate, there is difficulty in laryngoscopy. So we'll put a gauze piece and then do laryngoscopy to facilitate it.
No, but it should be, shouldn't it be this one, awake fiber optic?
Yes, sir, it could be awake fiber optic is the first choice.
Not could be. It has to be. You cannot do it as like normal laryngoscopy. Okay.
And we use a gauze in the cleft palate case. We put a gauze in the mouth in the defect, and then we can do the laryngoscopy.
No, actually, cleft palate is something else. Okay. Cleft palate is something else. In cleft palate, there is only, you just have to be careful you don't damage it. There is no actual difficult, but in these patients, you are not able to visualize it.
Right.
Okay. This Pierre-Robinson or trick. What is there in Treacher-Collins syndrome?
No idea, sir. Clipper field ka pata hai usme, sir.
So you just need to have few words about it. Okay. This is least likely to be asked to you. Actually, the people who are going for the Saudi Commission evaluation, they don't worry, they will not ask you in our exam. But in this our Saudi Arabia consultant interview, this is very important topic. We will, I think we will discuss this topic separately with you people. Okay. So I think we are finishing this discussion. Thanks a lot for your presence. And I just tried, because at the moment we are just trying to have a crash attack on different units. Okay. So maybe I will not be able to take it at night today. I will try. If I manage, I will do neuro and trauma. Okay. Otherwise, if not tonight, then tomorrow, inshallah, we will be targeting the trauma and neuro. Okay. So any questions before we finish?
Almost done. Thank you.
Okay, so just to summarize, please remember one thing: whenever a pediatric case comes, you just have to focus on the common things first, and just try to, when you are revising it in last few days, like once you finish this discussion, just open the number of topics and just try to fit in the common things, and you will find in every topic few words only. Okay. Few words in specific, which are specific to that disease. Otherwise, if you are safe in the basic conduct of anesthesia in pediatric or this one, I guarantee you that you will not face any problem. And some of the people on home, I become hard. Please don't mind it. It's for your betterment. And just try to focus on the words when you are telling history examination or any word. Any investigation you are telling, but you are not telling the reason, the examiner is actually irritated. If you are using that, I will be doing CBC for this, LFTs for this, echo for this, CBC, like whatever. So then it will be easy. Similarly for history, for examination, don't because long case is separate thing. In long case, they are asking you the details. In OSCE exam, they are trying to see some of your skills, communication skills or examination, whatever. In table viva, they are just trying that a discussion between for example, you can say the discussion between a senior anesthetist and a junior anesthetist in the operation theater, or discussion between an anesthetist or a surgeon. That's what table viva is. You just have to be very focused. You have to use meticulous words and just try to have a plan for basic answer. Basic answer will be majority time evaluation on the basis of history examination and relevant investigation to see whatever specific thing you want to see in that specific disease or a specific age group. Okay, so that's my message. Thank you very much all, and all of you are requested to subscribe the channel so that you are able to, and the people like who are able on focusing on the English. So I have made a playlist. Okay. And once you visit the channel, you just try to see the playlists, because I have tried to make the playlists, and so that you will be able to find the relevant discussion which have been done before. You will find it because I have recently shifted from our native language to English. So later on, we will build up the pool for all topics in English as well. But at the moment, all the topics before, actually now its repetition has been started, because majority of the topics we have done already, at least once. Okay. So thanks a lot. And any suggestion or any help or any guidance will be appreciated. I really thank Professor Akhtar Waheed, who is our convener back in Pakistan of our exams. And thanks a lot for this is highly encouraging for me, his presence. And I will be very happy if my all other seniors also join me and help me. Okay. Thanks a lot, everyone. Bye-bye. Assalamu alaikum.